Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hey everyone, and welcome back to the Gastro Girl podcast. I'm your host, Jacqueline Gollin, founder of Gastro Girl, and your partner on this journey to better digestive health. Today we have a very special episode produced in collaboration with the American College of Gastroenterology's Patient Care Committee. We're exploring the latest clinical guideline update, Preventive Care in Inflammatory Bowel Disease, or IBD, and what that really means for patients. I'm thrilled to welcome two outstanding experts who are key authors of this important new guideline. We have Dr. Francis Farraye, who's director of the Inflammatory Bowel Disease Center at the Mayo Clinic in Jacksonville, Florida, and Dr. Freddy Caldera, associate professor of medicine at the University of Wisconsin School of Medicine and Public Health at Madison. Thank you, Dr. Farraye and Dr. Caldera, for joining me today. We're so excited to have you on the show.
Good. No, thanks for having us.
So we're going to jump right in because we have a lot to cover today. I guess we'll begin with why does preventative care matter in IBD? Dr. Farraye, do you want to take that one?
Sure. This is an area I've been interested in for well over 15 years. I saw patients with inflammatory bowel disease on immunosuppressive therapy. In those days, it was mostly steroids and thiopurines and infliximab. And we would see any number of infections that I knew could be prevented by appropriate vaccination. And so that began kind of my career in this area. And then Dr. Caldera and I started working together probably well over 10 years ago. And I think that we've been able to kind of move the field forward. The issue for us is that many of the patients we see with ulcerative colitis and Crohn's disease are young. They really have no other medical issues. And the only contact they have with the healthcare system is with us as gastroenterologists. And that's the GIMDs, the nurse practitioners, physician assistants, and nurses that comprise our team. And we realize that sending patients back to their primary care provider to receive vaccines wasn't really working. They're very busy, just as we are busy. And that basically led to my approach, and I think Dr. Caldera's approach of taking more ownership in managing healthcare maintenance for our patients with inflammatory bowel disease.
So you're really stressing the important role of the gastroenterologist in this preventative care with these patients, because they probably see you, or they do see you more than they see their primary care physician, correct?
Absolutely. Someone who has active inflammatory bowel disease will have multiple touch points with the IBD team throughout the year, especially soon after disease flares or after their diagnosis. So we have multiple times to touch the patient and get them on appropriate therapy, deal with vaccines, and several of the other issues that go with health maintenance that are quite unique to this young group of individuals.
No, thank you for that. Now, before we get into the highlights of your amazing guideline that both of you were authors on, I wanted to set the stage for our listeners to really understand why preventative care is important, what that means, and what are the most common gaps you're seeing in preventative care among IBD patients? And either one of you can take that question.
I think when we're talking about preventative care, whether we obviously will delve into vaccines, but in an ideal world, someone wouldn't have IBD, right? And we wouldn't put them on different immune modifying therapies. Some of these therapies carry some risk, whether it's a risk of herpes zoster or whether it's a risk of skin cancer. And while now we thankfully have so many therapies where we can get people better, if we know someone's at an increased risk for a adverse event from their medication or the disease itself, and we can now prevent it, especially in this young, healthy person where, that adverse event may lead to either chronic issues or a new medical condition. I like to tell my patients, you already have enough. Why don't we prevent what we can do? That way we can keep you better and you can kind of keep living your life and not have to see the doctor as often.
No,
So that's kind of like a very simplistic way.
no, that's important because these are the things that we don't often think about. Those medications and those different cocktails of mixed therapeutics that patients with IBD may have to have, they do come with potential risk. And doesn't it affect their immune system? So you want to make sure that they're protected from things that possibly could affect them down the line.
I want to make a point there. Although, yes, the medications that we use can affect patients and put them at increased risk for vaccine preventable diseases, having ulcerative colitis or Crohn's disease by itself, there's an abnormal immune system that leads to the disease. And multiple studies have shown that even before introducing medications that could affect the immune system, our patients are at increased risk for things like shingles, pneumonia, respiratory syncytial virus. So having the disease itself is a risk factor. The medications potentially make it a higher risk, and that's another reason why we need to intervene.
No, thank you for clarifying that. And, we're not trying to scare patients at all, but we always want to focus on the education of patients. And this is such an important conversation. So thank you for clarifying that and to bringing that to our attention, because that is a really key point. So vaccines can feel confusing for patients. And, there's a lot of noise out there, pros and cons. And especially if you're a patient that has a chronic condition like IBD, it really adds a whole dimension of stress because you're not sure what to do, right? So can you please give us some of your insights and frame this in the way the new guidelines have outlined this, of what's safe, what's not, what patients should know, and can just basically walk us through the key vaccine requirements for IBD patients?
Yeah, I'm glad to. And just to build on Dr. Farraye's last note, that truly, IBD, untreated IBD is not good, because you're not healthy. And by far, the worst drug associated with the most complications is prednisone. So, there are some people who feel okay on prednisone and might not have any immediate, side effects from the drug. And at times I've seen people be like, why can't I just stay on prednisone? By far, prednisone has an increased risk for getting hospitalized for influenza, pneumococcal pneumonia, shingles, and etc. But yeah, I think these guidelines come at a right time, because regretfully, the message that's coming from public health is mixed at this time, where it is too bad that that is occurring. But anyone listening should know that vaccines are safe. There is no study showing that receiving a vaccine is associated with any disease flare. Zero. There's no, in any immune-mediated condition. So vaccines are safe. And why do we vaccinate someone where, even one of my patients told me, why do I need to get so many vaccines? And I started talking to them and let them know that the goal of vaccination is to basically control how you're exposed to an antigen. And this really started with COVID, right? Where it's like, why do I need another booster? Well, we know SARS-CoV-2, the virus by itself, it can kind of stimulate your immune system in an uncontrolled manner. Or you can vaccinate someone and introduce the antigen and provide protection against it. And that's really the principle of all these vaccines, is you're building defenses against something. So if we start out with pneumococcal pneumonia, there's papers showing that even at the diagnosis of IBD, you're at increased risk, for pneumococcal pneumonia that can cause lung infections, bloodstream infections. And what's new in the guidelines, so I'm going to try and hit some of the new things, is that now we have two vaccines where it's kind of one and done. Where if you haven't been vaccinated, you can get a PCV20 or a PCV21. We don't have any data that's one or better, and that's it. And then at age 65, you can get another one. So it kind of simplifies, because pneumococcal pneumonia recommendations have always gotten very complicated, whether you got this one, then 5 years apart. So we have a figure in the guidelines that someone can look up that kind of summarizes that.
And I just want to clarify for our listeners, in case you're jumping in at this time, we're talking specifically about patients that have been diagnosed with inflammatory bowel disease, whether that be Crohn's or ulcerative colitis.
Correct. So for pneumococcal pneumonia, that's any adult 19 and up should get vaccinated. And for maybe a family member that's listening, and you can find out a new recommendation from the CDC that said anyone 50 and up now can also get the pneumococcal pneumonia vaccine. And now if we go to shingles, so for everybody listening, shingles is the chickenpox virus, whether you got natural disease or you were vaccinated against chickenpox. It's the virus that lives in your body that can come back and cause a rash. Sometimes it can affect the face. We actually published a paper, me and Dr. Farraye, that showed that having IBD, if you get an episode of shingles or herpes zoster, you're at increased risk for complications of that, which can result in like a permanent rash with neuropathic pain. You can get shingles impacting your eye. You could get hospitalized. So it could be pretty serious. So we have a 2-dose shingle vaccine that anyone 19 and up who has inflammatory bowel disease can get. We're still recommending the influenza vaccine. The only thing that's kind of new is for older adults that are 65 and up, they should get a influenza vaccine that's meant for them. So when you're 65 and up, your immune system might not respond as well to the normal vaccine. So there are 3 different types that you can get. And the other one will be COVID. So at the last ACIP meeting, they still showed that COVID, or the infection from SARS-CoV-2, is still associated with a lot of complications, and that getting a COVID vaccine can help reduce complications such as blood clots, hospitalization, and etc. So that's still something that I think will be needed in the fall.
I just want to add a couple things to what Dr. Caldera has said. Again, he's quite modest. Together, we've been able to really move the needle, I think, on improving care for individuals living with ulcerative colitis and Crohn's disease. In addition to showing that patients with IBD have an increased risk of complications, we've shown that the vaccine Shingrix works to decrease the risk of developing shingles. So there's proof that it works specifically in patients with ulcerative colitis and Crohn's disease. Another point I want to make is for those parents listening who have children with inflammatory bowel disease, there's something called a cocoon strategy. What a cocoon strategy is that if your child is immunosuppressed, you don't want to inadvertently bring into the family influenza or pneumonia or any of the other potential infections. So it's important for the immediate family members, the grandparents, the parents, brothers, sisters, to be vaccinated as well, so they don't, by mistake, bring into the family an infection that then exposes the individual who's immunocompromised to developing the infection and having significant consequences.
And one more that I wanted to mention is RSV. My B's at times sound like B's, so I make sure I pronounce it correctly. That's respiratory syncytial virus. And that's where I like to make a point to talk about that with patients, because they're like, what are you talking about? I have to get the flu, I got COVID, what's this RSV? And most people have somewhat heard of RSV in the past because, infants or young children can be at increased risk from RSV and can get hospitalized and they can get pretty sick. But for a long time, testing wasn't available. Most people remember from the initial COVID of getting a PCR test, right? So over the years, more testing was done. And what research has shown is that older adults were at increased risk for RSV infections that would get them hospitalized. So we published a study showing that if you have IBD, you're at increased risk to get hospitalized from an RSV infection compared to if you don't have Crohn's or ulcerative colitis. So the CDC recommendation now is if you're at increased risk for a serious disease or getting hospitalized, you should get vaccinated. So right now it's a one-time dose. There's 3 different vaccines available. If you're 50 and up, you can get the Pfizer vaccine. And if you're 60 and up, you can either get the Moderna or the GSK vaccine. So that's something I recommend. I typically tell people to get it if they haven't gotten it, get it around August, because RSV follows the typical flu season.
The other point I'm going to make is that, look, I think Dr. Caldera was right on target. This is a politically charged area now, and there's lots of vaccine misinformation going around. And it's important that healthcare providers point out the positive benefits of vaccine, the safety of vaccines, so that we could kind of overcome some of these concerns. And I basically tell people, I'm old enough to have received the shingles vaccine and the pneumonia vaccine and the RSV vaccine. I don't have inflammatory bowel disease, but I believe so strongly about the safety of these things that hopefully that will convince some people. There's one other point I want to make, specifically regarding the measles outbreak that's going on in the country now. Measles is a very unique virus in that people who have natural infection with measles, who get a case of measles, it's not just the measles. You can recover quickly from the measles, but the immune system is altered and it leads to something called immune amnesia. Basically, what it means is that if you get active measles infection, some of the vaccines that you received before, some of the previous normal immunity to the flu and other infections are decreased. So it's more than just measles. And I really do think this is a crucial aspect that we have to address as gastroenterologists, overcoming vaccine hesitancy.
No, that's a great point. And I think, for patients, we don't want to make this a political issue. It really is a shared decision-making process with the physician. So this episode, and I want to say this because, we all have our opinions and our viewpoints, and depending on what data we're looking at, what experiences we've had, patient feedback. So we don't want to make blanket statements. We're focused on your paper, your excellent work, and your guidance so that patients understand their risks, why these vaccines are recommended, so that they can then have meaningful conversations with their providers like yourselves and make the best decision for their particular health situation. Do you agree that that's a fair way to approach this?
Absolutely.
Yeah. And I would say, look at the science, because, the science doesn't have a political side. So why is measles an issue? The question is, does it cause autism? So the science is overwhelming that it doesn't, and for any patients listening, so a question that I've been getting is the measles numbers are not going down, and they're not going to be going down. And when you talk to other experts, they tell you the measles numbers are probably lower than we have because of underreporting. So right now, someone should know that if they've been vaccinated against measles, and before pre-COVID, like vaccination rates for the MMR vaccine were pretty high, they should not be considered themselves at risk. They should look at immunization records, and if they received the 2 doses, they should know that a blood test to say if you're immune to measles is not accurate. Like, I wouldn't want someone to be asking their provider, hey, can you check a blood test, because you're kind of opening Pandora's box. Those tests are not recommended by the CDC to check if you're immune if you have appropriate immunization history. So if you have your immunization records and you said, hey, I got 2 doses of my MMR vaccine, you shouldn't check them. There's no role. We published a study a while ago showing that if you had IBD, your antibody levels to the measles were the same as someone without IBD or any therapy. But it could just create this whole big hesitancy, right? Like, oh, I don't want to travel. I don't want to do anything because I'm not immune. And people should know that measles is a live vaccine. So something we wouldn't recommend for someone on a biologic or a small molecule. We also wouldn't want someone to take away their therapy and potentially put them at risk for flare to get a live vaccine.
That makes sense. So this is good information. And is this all in the guidelines? Those are the new guidelines.
Absolutely.
Yep.
Is there anything else patients should be aware of in their conversations with their providers, like that they should, how they should approach the conversation?
A couple of other things that we covered. So vaccine was a good large chunk of the guideline. And by the way, that's an updated guideline from the 2017 one that was initially published in the American Journal of Gastroenterology. So there are other things we address. So for both men and women, we know that for individuals with Crohn's disease, there's an increased risk of melanoma. That's independent of the drug treatment. And then some of the medications that we use increase the risk of something called non-melanoma skin cancer. So our recommendation is that every patient with inflammatory bowel disease see a dermatologist. The dermatologist can then do a full skin exam and assess their risk of developing these malignancies. And they, again, as you said, by shared decision making, can determine how often they need to come back. And I got to tell you, I've seen a large number of patients that are perfectly healthy. I don't do skin exams. I must admit that I don't do a full skin exam. And I send them to the dermatologist. And these are individuals in their 40s and 50s who have a small melanoma that's cured by local excision. So that's the first thing. The second thing that we need to talk about is osteoporosis and osteopenia. So having inflammatory bowel disease, in particular Crohn's disease, puts you at risk for developing weakness in the bones. And that's either called osteoporosis or osteopenia. And that puts you at risk for bone fractures. In addition, Dr. Caldera pointed out that corticosteroids, in addition to being the increased risk for infections, also takes the calcium out of the bones and puts you at risk for developing these conditions. And so we do recommend that if you have risk factors, you're postmenopausal, a woman, you've been on steroids for more than 3 months, that you get a bone density scan. And if it shows a problem with the bones, then I refer them back to their primary care provider or an endocrinologist for treatment. And then for women, some of the medications that we're not really using all that much anymore, the thiopurines, for example, they are associated with an increased risk of cervical cancer. And so when a woman who has HPV infection and is taking one of these medications, it can accelerate the risk. And so we recommend that women see their gynecologist, let them know, the gynecologist, that they have inflammatory bowel disease, let them know what medications they're on, and then the gynecologist can do appropriate testing and then put them in a protocol for follow-up Pap testing. So there's more than just vaccines. And this is why our jobs are so busy. But again, we pointed out very early on that if they're not seeing their primary care doctor, no one's telling them to do all these things. So it's important. And both Dr. Caldera and I have checklists that we go over with patients. And those are available on the internet, simple checklist of all the things that need to be looked at. And you can bring them into your primary care doctor and go over them. Dr. Caldera is leading an effort for the Crohn's and Colitis Foundation, keeping those checklists up to date.
No, that's great. And we'll put the links to the Crohn's and Colitis Foundation and any other resources that you suggest so that patients can easily access. I really love that you pointed out this is almost like a multidisciplinary care model in that there's so many aspects to a patient's IBD journey. And it's not just the gastroenterologist, but it can seem like that. And to have a preventative care guideline for these patients is critical. And the more patients know that there are all these things, I do have to tell my gynecologist, I do have to tell my endocrinologist, I do have to tell my dermatologist, because all of those things are related to my overall condition, and I need to let everybody know and be on the same page. So this is a really important conversation. I'm going to keep saying it because it is. Is there anything else? Are there any common myths or misunderstanding about these screenings for patients that you want to call out before we move on to the next area?
Well, and maybe not the myths, but at times when someone's sick, a lot of what we're mostly talking about, the patient wants to know is, get me better, right? And obviously the field has moved with different therapies where now we can be more proactive and be like, we could check drug levels, check stool tests, check a calprotectin. But once you're better, it's still important to go to your gastroenterologist, where that way you can talk about like, okay, how do we make sure we keep me better and not have an X complication? Am I due for a DEXA screening because I was on so much prednisone? And do you need to check my vitamin D? Or it's kind of that part that like don't make sure you kind of follow up because so much time is taken up and effort from the patient and provider of let's get you better, that's when the health maintenance or the prevention can kind of fall to the side, that it can be a lot to take in, right? Like, oh, I gotta switch my therapy and I gotta go do an MRI. That at times from a patient you may not be thinking of like, oh yeah, I gotta get that DEXA, right? But once you're better and we're talking of like, what are we gonna do to make sure you don't need something else, I still think that's a key part of taking care
No,
of
thank
someone
you
with
for bringing
IBD.
that up. And, now we're moving on to a really critical area. And we just did a podcast episode with Dr. Lori Kiefer to address some of the mental health aspects of IBD. And we know that mental health plays a huge role in IBD as in any chronic condition. How should patients approach their providers about some of the things they maybe experience if they feel depressed or anxious? Maybe they're smoking or they're using alcohol. Like, how can we? I know that it goes both, there's two parts to this. The provider needs to ask the questions too, but the patient has to feel comfortable and not embarrassed making the connection between what they're experiencing with their disease and also their life and how it's been impacted.
So what I've told some patients at times is that you're not alone. You're not the only one. They should know that this is a common issue. A lot of patients are healthy and now have this chronic illness that we can tell them it's very treatable, but this can have severe impacts. And at times have patients told me it's like an invisible disease, right? Because you feel fine, but now when you don't, you look fine, I'm sorry, but you don't feel well. You might be tired or you might not want to go do events. And that can be really hard mentally, or even just the fact that, hey, we're going to switch therapy. We might need to wait a while to see if it works, or you might need to be on corticosteroids. So they should feel that, this is not a complaint, that they're not alone, that this is a common thing that happens and that we see a lot, and different people need different things. So at Wisconsin, we have a dedicated health psychologist, that's there to help them dealing with coping with different mechanisms. If someone shares this with me, you know, as part of knowing someone's history, I typically know their hobbies. And as they're getting better, I'm like, hey, are you going to work out? Are you going, if Dr. Farraye was my patient, first thing I ask him, I'm like, are you fishing? Because the IBD can impact you in so many ways that people severely limit their lifestyle. And we want to make sure that they're staying healthy and not coping with the wrong way by either smoking, which smoking is the worst thing you can do for your Crohn's. It's like
Oh, wow.
gasoline. Lots of studies showing that smoking, you're more likely to lose response to biologics. Your disease is harder to treat. You're more likely to have surgery. We also don't want someone coping with alcohol, right? Where alcohol has its own bad effects. So we're making sure that if you're a patient that's struggling with depression, anxiety, you reach out for help, whether that's going to see a health psychologist, going to see your primary care, letting your gastroenterologist know so that within that system or that clinic, you can get the help you need and knowing that they're not alone.
That's great insight. And I just, it's easier said than done for a lot of patients, right? In your practice, both of you, Dr. Farraye, Dr. Caldera, how do patients bring these areas of concern up to you? What are examples of how they would bring it up in conversation? And again, a lot of it falls on the provider to ask the question, but sometimes they're so busy, they maybe have 12 minutes, 15 minutes or less. How can a patient, or how do patients in your practice address this with you first? Like some examples.
So typically I will ask the patient as part of my review of systems, how you've been feeling. Just like Dr. Caldera, have you been getting out and doing the things that you enjoy? And if they're on the line, if it's a telemedicine or face-to-face and their significant other is present, I ask the significant other, how is your partner doing? And often the patient doesn't want to offer that information. Now, some people will come in and just say, look, I am so down. But I think that's kind of the exception rather than the rule. So I think it is important to ask that question more, just as important as asking, do you have blood in your stool? Do you have diarrhea? Can you go to work? Can you do the things that you enjoy? How is this disease impacting? And then to let them know that if they, at least for me to know, if they answer in the affirmative that it's having a problem, we also have access to psychologists, but there are online programs that could help those patients. And if we don't address the mental health issues, we're leaving something behind that goes a long way, because often patients will determine that they're in remission. Just like Dr. Caldera said, there's no active disease, but they're still feeling down. They're afraid to go out. We need to address those concerns if we're going to really have that patient go to the next level of being well.
Thanks. And Dr. Caldera, just to finish this up, what about the patients where the providers may not ask that question? How have you seen patients approach you, or how do you suggest they approach their provider and just offer that information? And like you both already said, it is so hard for patients to do that, but we want to encourage them and empower them to bring it up, even if the doctor doesn't ask them. How can they do that?
I think if they're, so what a couple of patients have done is they sent me a portal message before and said, hey, I want to talk about this, because sometimes it's easier not to have that conversation right away. If at the end of the appointment, I always ask, is there anything else I can do for you? Because typically it's the last question, right? It's like as you're walking out, they're like, oh, by the way, so to try and prevent that and make sure someone feels heard, I say, is there anything else I can do? I would say they shouldn't expect a negative response. From a patient perspective, we know this is an issue. And whether that provider, your provider has like all the resources, there are many resources out there that can be used. So definitely reach out, because the goal of treating IBD is not just for you to feel better, but to almost feel like you don't have it. And that means you're back to yourself, you're happy, you're doing whatever you wanted before this. And I joke with my patients, I'm like, yeah, I got to go see Caldera again, but I feel fine. Like they're doing so well that they almost forget you have the disease.
Oh, this is such great information. Just as we wrap up, we don't have too much time left, but I wanted to just address the coordination of care. We kind of touched on this, but IBD and like other chronic conditions, it feels like we're juggling multiple providers, and we are. How can gastroenterologists and primary care doctors work together? And what is the patient's role in all of this?
Well, I think it's important early on, when establishing a relationship with your provider, whether it be a physician, nurse practitioner, or physician assistant, is for we as providers to make it clear what's in our bailiwick. And I'll let them know that if you have any GI issues, I'm going to be the person to address them. But if you develop chest pain, I don't want you calling me. I want you to call the primary care provider. I'm going to let the patient know that any interaction I have with them is going to be sent to their primary care provider or their dermatologist or their rheumatologist, so that they know what my thought process is. And that way, the other individuals who are involved in that patient's care know what my thought processes are. But again, it's early on in the relationship that we say that we'll take care of these issues, but don't forget you need to see your primary care doctor if you need a cholesterol check or your blood pressure check.
Yeah, and Dr. Caldera, what advice would you give to patients who may feel like their doctors aren't communicating?
I think that's where obviously people that are listening to you, right, are very proactive and pro health. So if you have questions of like, hey, what should I be getting? What's meant for me? I think going to the Crohn's colitis checklist is a very easy thing, because the checklist mirrors the guidelines. So we don't have to have everyone reading the guidelines and saying what to do. The checklist is very simple. Let's say you have a GI provider that may not have vaccines in their clinic because, you know, they're a small clinic. Use a pharmacy, or talk to your primary care provider. Do you have some of these vaccines in clinic? And you can use, your local pharmacy, just like when people were making their COVID appointments, you can make an appointment to get your shingles vaccine. Or you could bring that checklist to your primary care doctor and said, hey, these are all the things that are recommended for me. Many times, primary care providers reach out to me, and I'm always glad to talk to them. So, there can be a way to make that communication happen. If a patient goes in and says, hey, can you just check with the GI doctor if there's any concerns? I think being proactive about your health is completely okay and not taken in the wrong way at all.
In terms of the guidelines, what are each of you, and Dr. Farraye, you can go first. If you could sum up some of the key takeaways from your perspective for the guidelines for patients.
So I'll let Dr. Caldera hit the high points of vaccines. I'll do the non-vaccine recommendations. Inflammatory bowel disease is a systemic disease. It's not just your gut. We do have to worry about skin. We need to worry about your bones. In women, we need to worry about cervical cancer. And already you hit the high points of the importance of mental health and behavioral interventions. Everyone should stop smoking, whether they have ulcerative colitis or Crohn's disease. So don't just concentrate on your GI symptoms. It's a systemic disease. And remember that other parts of your body need to be, health maintenance for other parts of your body need to be addressed. And again, our guideline didn't go over colon cancer screening. Patients with inflammatory bowel disease, certain ones, not all, have an increased risk of colon cancer. But I'm pretty sure GI doctors and their teams are pretty much keyed into that issue. We want to make sure everyone else is keyed into these other issues as well.
Thank you so much, Dr. Caldera.
From a vaccine standpoint, I would say vaccines are safe. They won't worsen IBD. The whole goal of vaccination is so that if your immune system is not now overly stimulated and you get really sick and might need antibiotics, might be at risk for C. diff, right? Because if you get antibiotics, the goal is to get, the respiratory virus vaccines. So that's flu and COVID during the fall season. If you're eligible for the RSV vaccine, so that's 50 and up, you should get that. You also would want to get a pneumococcal vaccine that's against a bacteria that causes lung infections, infection in the blood, infection in the brain. You would also want to make sure you get a shingles vaccine. That's a 2-dose vaccine. If you get the shingles vaccine, know that you will feel bad about the next day. You will get, some soreness, feel fevers and chills. So if you want to don't get it on a day you're planning to do something fun. I joke with my patients, if you want to get out of your honey-do list, then get it the day before, and just because the first time is bad doesn't mean the second time will be worse, but we're really just trying to keep people better. That's the
and
whole
safe
goal.
and keep them safe.
Well, this has been such an important and enlightening conversation. Thank you both, Dr. Francis Farraye and Dr. Freddy Caldera, both of you key authors of the new ACG Clinical Guideline update, Preventive Care in Inflammatory Bowel Disease. Thank you again for sharing your expertise, and to the American College of Gastroenterology's Patient Care Committee for collaborating with us on this important episode. Remember, preventative care isn't just about checking boxes. It's a vital part of staying healthy and living well with IBD. Don't forget to talk to your healthcare team, stay up to date on vaccines and screenings, and most importantly, know that you're not alone on this journey.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.